Hello and welcome to this video. This is on behalf of the University of Manchester Ophthalmology Society, and we're going to cover age-related macular degeneration. So age-related macular degeneration is actually the most common cause of vision loss in developed countries, and it's actually the most common cause of blindness in the UK. Now AMD affects the back of the eye, just where the cursor is, and it's actually this area called the macula that is affected. And it's this macula that's responsible for high resolution central color vision. Now this sensitive area of the retina gets damaged when the layer between the retina and blood vessels break down, resulting in fluid leaking and scarring. And when it becomes advanced, it destroys the central vision that we use to look straight ahead. We use this vision to recognize faces, read books, use our phones. Now fortunately, because it's just the center that's affected, peripheral vision remains intact, and this means that patients with AMD will retain some level of independence. Now we're not too sure what causes this condition, but what we do know is that it's probably a mixture of genetics and environmental factors that play a part. Now the main risk factor, as the name suggests, is age, and it's mostly people above the age of 60 that get affected. Now smoking is another big risk factor due to the oxidants in cigarettes that damage the retina. And a recent study in the BMJ actually said that smokers are 4 times more likely to develop AMD than non-smokers. Family history and cardiac risk factors also play a part, as well as Caucasians that are more likely to have AMD. Now there are 2 main types, dry and wet. I'll start off with dry. Now, like I've written, 85 to 90% of cases of macular degeneration are dry. Now initially they may have good central vision, but then they may suffer with things like difficulty reading, limited vision at night, and fluctuating vision. Now in the dry type of macular degeneration, the deterioration of the retina is associated with the formation of these small yellow deposits known as drusens under the macula. And this leads to thinning and drying out of the macula, causing the macula to lose its function. Now drusens are essentially acellular debris consisting of certain waste products from the cells in the retina, and the amount of central vision loss is directly related to the location and amount of retinal thinning caused by the drusen. Now dry AMD tends to be chronic and slow progressing, so it can often take quite a few years before these symptoms come about. A certain number of these dry AMD cases end up progressing and becoming wet macular degeneration, which is often more severe and more rapidly progressive. So let's talk about that now. Like I've mentioned, the other type is known as wet macular degeneration. Approximately 10% of these cases are wet. Now in the wet type of macular degeneration, abnormal blood vessels known as choroidal neovascularization grow under the retina and macula, and these new blood vessels may bleed and leak fluid, causing the macula to almost lift up from its normal flat position. Now because the macula's new position, straight lines now look wavy because the macula is no longer smooth. Now when choroidal neovascularization is developed in one eye, it's very common for it to occur in the other. And wet macular degeneration may also progress more rapidly than the dry one. Sometimes the vision loss can occur in just a matter of days. Now one last point is that despite dry AMD being characterized by drusens, remember that in real life probably both dry and wet tend to have drusen deposits. So how does it present? Now AMD affects both eyes, but it is often asymmetric. In the early stage, patients are often without symptoms, and sometimes they notice mild symptoms such as minimally blurred central visual acuity, reduced contrast, changes in the way that colour is seen, and mild metamorphasia. So subacute vision loss, difficulties in dark adaptation, fluctuations in vision, and photopsia. Now photopsia refers to distorted lines that they may see straight as before, which are now curved, and this blurred vision means that often these patients will struggle to read and see faces. They may also see these dark spots in their vision, and we call these scotomas, and likewise these definitely affect patients when reading. Now in terms of diagnosing this condition, the first thing that anyone would do is a referral to ophthalmology, and there they will do the Snellen's chart, as you can see from this picture. AMD will show a reduction in how many lines they can read. Then the next test that they would do is the Amsler test, the Amsler grid. Now this is a grid of horizontal and vertical lines, and AMD patients will complain that they are distorted or curvy, like I mentioned, because of the macula's new position. Now normally when we do an Amsler grid, you get patients to focus in the center, and you would ask them if they have any blurred edges or distortion, and that can raise the suspicion of AMD. However, to fully diagnose this condition, we do need to look into the back of the eye, and it's there that we will see certain signs. So this is the first one, and we can see these yellow drusen deposits, and as I mentioned, these are characteristic of dry macular degeneration. Wet macular degeneration is slightly different, and it's more characterized with hemorrhages and inflammation. Now, the gold standard is fundus fluorescein angiography, and OCT is really good at detecting retinal thickness, and as I mentioned, the retinal thickness will be reduced. It's going to become thin over time, and this is a really good test for it. Now in terms of the management, as I've written, there's no real treatment for dry. There is some things that we can use for wet, and they are anti-VEGF. So VEGF stimulates angiogenesis, and this agent inhibits this, so we can help to slow down the progression. This is actually given intravitreally, so patients will often need to continuously come and see the ophthalmologist for their treatment. So as I've written, there is no treatment for dry, but we can try and facilitate care to improve their life, and we can usually refer these to departments like occupational health, which can help them with things around the house, making their home more safe. Bright lights at home, walking sticks, precautionary measures in place for going up and down the stairs, magnifying lenses especially for reading, and various other home care that can be arranged to greatly improve these patients' quality of life. So just to finish things off, just a couple questions. Which of the following statements regarding macular degeneration is true? So drusens are characteristic of wet macular degeneration. Well, we know that's not true because it's dry. Photodynamic therapy is another treatment that is traditionally used for wet macular degeneration. As I mentioned, dry macular degeneration doesn't have any treatment. Asian ethnicity is a risk factor. Well, we clarified that it's Caucasian. Male sex, though gender doesn't really play a part so much. But what definitely is true is that wet macular degeneration carries the worst prognosis. So that's the answer for this question. And another one. A 67-year-old woman presents for review. She has recently been diagnosed with dry, age-related macular degeneration. What is the most effective intervention to slow the progression of this condition? Well, if you look at all of these options, there is one big risk factor that plays a part, and that is smoking. So stopping smoking will help reduce the progression of this condition. So that's all I have for you today. Thank you very much if you made it this far. Make sure you smash the like button as always, subscribe to the channel, share it with as many people as possible, and I'll be back with another video soon.